I'm very excited. It's amazing to see this room full of people interested in this rare disease in CDG. I want to begin giving thanks to Vanessa, to the organizers, to inviting us to present our preliminary data of our research about neurological aspects in CDGs. It's a big challenge because there are more than 100 CDGs, different CDGs. And in this slide, I want to show you some clinical things or key neurological things that can give us a clue about what type of CDG is underlying the neurological disturbance. We can begin with the intellectual disability. There is a wide spectrum of intellectual disability among all the CDGs. We have those CDGs with a very severe affectation, others where we can find variable abnormalities in the intelligence quotient, and others that have no kind of intellectual disability. If we are talking about the cranial circumference, which means how is growing the brain inside the cranium, you can find diseases, the majority of them where we see microcephaly, and some others where we find microcephaly. This is a big head. Epilepsy can be also a key trait, a cardinal thing for us to suspect which kind of CDG is underlying, and is a great feature, and sometimes could lead to an encephalopathy, epileptic encephalopathy, in this kind of diseases, particularly in the last ones, giving really an encephalopathy in the infant. And then we have a variable epilepsy that may be treated with only one drug in other diseases like PMM2. We also used to find abnormal muscle tone, like hypotonia is the more prevalent one, but also extrapyramidal things, spasticity, that is an increase of the tone, or involuntary movements in the end glia1. We can have also skeletal muscle disease in some of them, myopathy, myasthenic syndrome. We can have abnormalities in the peripheral nerves, and finally, we can have ataxia. So as you can see, the manifestations regarding neurological aspects can be very varied, and is really complicated to know what is going to happen in every single disease. In Spain, this is the map that we have. We have a national registry, and we have a 76 PMM2, and then this variety of more rare kinds of CDGs. I am going to talk particularly, basically, on PMM2. We have a national network working on CDGs. We have begun with PMM2 because it's the most prevalent. It was more easier to develop the pilot. And you can see here the tertiary hospitals, where these patients are treated. Some of them are included in a project from the ministry, and all the others are all collaborating in this network. We have four important aims. The first one is to develop and validate scales for the quantification of severity of neurological symptoms, both in children and adults, to validate a volumetric method for the study and monitoring of the cerebellar involvement, to study the correlation among the clinical, radiological, biochemical, and molecular issues, and finally, but not less important, to develop a professional national network to guarantee to unify the clinical practice and share among the doctors the knowledge and the guidelines. As you know, one of the main features in PMM2 is the cerebellar involvement. At birth, most children have an hypertrophy of the vermis and the cerebellar hemisphere, followed by a progression towards atrophy. And many key neurological symptoms found in this PMM2 are explained by these cerebellar abnormalities, like ataxia, which is this gait instability, dysmetria and tremor, abnormal eye movements, dysarthria and this slurred speech, and cognitive deficits or low intelligence quotients. I will talk about the three aspects that we are researching at the present moment. The first one is trying to evaluate carefully, accurately, the neuroimaging. The second one is trying to delineate better the motor disturbance. And finally, to perform a psychometric evaluation, a cognitive and behavioral evaluation. Regarding neuroimaging evaluation, we have some questions. The first one, is this neuroimaging progression real? Is real there is an atrophy? The second one is, does it correlate with a measurable clinical worsening or not? Is this progression pointing toward a therapeutic window? Maybe we have to act at the beginning when this atrophy is not evolutioned. Regarding the clinical or motor disturbance assessment, the questions are, is the motor phenotype improving with time? This is our sensation or feeling from the clinician. They improve with the time and they stabilize. Does motor disturbance correlate with any measurable aspect on MRI that we can predict, we can alert the parents what is going to happen? Can we measure and detect changes? So if we apply any therapy, can we detect the changes not explained by the evolution of the disease? And finally, the psychometric evaluation. Do PMM2 patients show a well-defined cognitive or behavioral profile? Can we help them? And regarding the last question, we are very worried about the behavioral phenotype of these patients because we know that maybe we can better help at the school the adaptations. And for the families, for the social living, for the normal living with these behavioral features. And we know that the cerebellum is very implied in some psychological issues like language disorder, working memory, spatial memory, attentional activation, cognitive processing, sensory acquisition and discrimination, and emotional modulation. And this is why we think we may perceive or being able to detect these kind of changes in these patients. Well, beginning with the clinical or motor assessment, we need to quantify. Why? Because if we apply a therapeutic agents, we have to be able to measure if the change is due to the evolution of the disease, this stabilization that we normally see, or is due to the therapeutical intervention. What is the big problem that ataxia rating scale have been developed for and norm for adults? But we are lucky because in 2014, Brandma saw that the ataxia score may be useful also for children older than 4. But we have to perform a correction because the normal development gives some skills that are going to influence these scores. But the very young child, younger than 4, cannot complete all the components because of understand issues, because of coordination and muscle tone. etc. Regarding those with more than 4 years old, we have applied the ICARS, and ICARS is the International Cooperative Ataxia Rating Scale, and it's a scale validated in adults, but also in some cases with genetic disorders like coenzyme Q deficiency and Friedreich ataxia. So it's a scale you can see here is evaluating the posture and gait disturbance, the kinetic functions with the hands, with the legs, the speech disorder, and finally the oculomotor disorder. We have evaluated 21 patients with PMM2 and 21 age-matched controls with 3 explorers blinded from each other. And we found that ICARS and every ICARS subscore were significantly different between healthy children and PMM2 patients. We also evaluate the agreement between these observers, and it was good too. And this is the representation between the patients here. This is a semi-logarithmic scale, so you can see here the 10 and then 100. 100 is the worst, and 0 is the normal for an adult. So you can see the controls are going through 5, going down with the age. This is a healthy children with 4 or 5 had some punctuation in ICARS. And then we have here the controls. As you can see, if you correct with the age, you can subtract 2 or 3 points, but not so much. So it's a good scale, we believe, to evaluate the clinical evolution in the motor disturbance. What about ataxia assessment in children younger than 4? Well, this is a problem. There are big efforts from some years from the Ataxia Foundation in the US, and we don't have no scale at the present time. But this is our aim for 2016, to develop and validate an ataxia rating score for infants and toddlers. Regarding MRI, we have performed volumetric analysis. You can see here a patient, which is 7-year-old, is a mildly affected. ICARS is only 18. The worst, remember, is 100. And he has a cerebral volume of 40 cubic centimeters. This is a healthy control, and you can see the difference. It's not an average, it's only a control, only one, but you can see here the difference is more than the double in the volume. And you can see here the fovea, the cerebellum is like a broccoli. So you can see here is like full, and you can see here all the spaces interfolia that is widening. We have also seen the evolution with time. This is one patient at 15 months, and you here can see the evolution more in this image. You can see this atrophy. When we measure, we see that the atrophy is not too much. It's only 7 cubic centimeters. But you have to take into account that the cerebellum is going to grow up with the children. So if we compare with the normal evolution of a healthy children, you can see healthy child, you can see here 75, and then the different get larger. Well, in all the PMM2 patients that we have evaluated at different time, at 2 points with the MRI, there was a progression even in a teenager. So in a patient older than 10 years, there was also a progression of this atrophy. Well, all the patients doesn't have this digital scan, so we cannot perform volumetric analysis in all the patients. So we try not to complicate it too much and to give an easy tool to measure. And we made this comparison between the cerebellum and the room, the posterior fossa, and see what happened with this fraction, like a proportion. The proportion correlates good with the volumetric analysis. This is when the volumetric analysis gives a big volume, the fraction is also high, and inversely. And this is just a qualitative imaging showing that the more affected you are with ataxia, so the worst ICAR you have, the worst image you have. So the more atrophy we can find. Maybe you can see here, this is the mildest boy we have here. And this is the worst clinically affected patient and his cerebellum. And this is also statistically correlated. So if you have a high ICARS, you probably have a low fraction, okay, proportion. And finally, we have talked about clinical, we have talked about volumetric and MRI, and now we are going to talk about psychometric evaluation and cognitive profile. We have performed 2 protocols, one for the older than 5 year and one for the younger. And what have we seen? That there is also a correlation between the severity of the motor disturbance and the intelligence quotients. Okay, the children with better intelligence had lower ICARS, motor abnormality. These are only 6 patients, so we have to go on this aspect and explore more, but, well, it's beautiful to see. Regarding cognitive aspects, we have talked about these executive functions, lack of attention, language abnormalities. In our short experience of these 6 patients, we have seen this lack of attention, this slow processing. That means if we gave them more time for the evaluation, they are going to reach better results. They need time, they are slow. And the definition of this cognitive profile is very important because it will help to adapt the academic materials, the adaptation at the school, and improve the psychological resources for the families to cope with frustration and temper tantrums and etc. And I will just share with you some slides about rare commons, which is something that I presented you in Barcelona 2 years ago. At that time, it was a dream. Now it's a reality. It's a website to share between families and doctors together, and families together. We know that families of patients suffering rare diseases share large amount of information in WhatsApp groups, in Facebook, and unfortunately this part of this valuable information is not available for the doctors, and we can learn too much reading these messages, but we cannot exploit it. Conversely, we normally use congresses, professional meetings, the email to share experiences and difficulties when treating these patients, and we do not have a tool to share all together and discuss about hypotheses and perform these group discussions. Moreover, many doctors treating rare diseases like me need help in my process of taking decisions from other doctors with higher experience. And as you know, clinical guidelines are not always unified or published, so every doctor does the best he can. So Rare Commons is an open website for both patients, families, and doctors. It requires registration and informed consent, so everything is secure. And we use one methodology already used in common diseases. We know that rare diseases with very low prevalence need this coordination that we are doing now between families, researchers, doctors through the world. Because for some of them, achieving this critical mass to increase the knowledge is really difficult using the traditional means. In Rare Commons, we have some benefits and commitments for families and for doctors. First of all, the commitments. We need the families to cooperate, providing clinical data, suggesting topics and questions, to identify the real needs of children that probably families know more than doctors, and providing access to their physicians, because we want to open this platform to everyone, and the expert will be the leader, and because we are not. We only have the tool, but we need everyone to collaborate. And what are the benefits? Improved competencies, because there is a lot of information in easy language, close monitoring of the child, because you are going to have a registration, improved care of children by facilitating the consensus among all the doctors, and finally, to interact and collaborate in a support group like Facebook, because we have a social part. This is how we work. Patients read a chapter, then fill a questionnaire. At every time they have the support of the group, and then they can get, when they finish the questionnaire, they can get the information of the whole group that I will show you later. This is the aspect of the questionnaires. This is from Yolanda Scott, which was the president of the CDG Spanish Association. These are all the topics that we are treating. They are chapters, exhaustive but simple. And this is an example of a questionnaire. For clinicians, we have some commitments to cooperate in the research, providing the clinical data, more complicated data perhaps than the families, and share experiences in the clinical practice, suggest new questions, enable access to the patients. And as a benefits, they will have the registry of their patients, a close structured work forum to put there the questions, the difficulties, to share with the others. We will have a bibliography and documentation of interest, like a library, and the opportunity to develop scientific papers as a group with all the information recruited in the platform. So this is what they have, the doctors community. We open in May in Spanish. In English will be open in September, and we have now 56 families collaborating and their doctors. The doctors will be always invited by the patients, and this is in this way because it's the only way to know that they have been informed that they participate in this community. We have 54 PMM2 patients, 52 from Spain, the others are Latin American, 1 COG8 and 1 NGLI1 at the present time. This is some of the results that we have at this time about first symptoms, ataxia, febrile seizures, peripheral neuropathy, epilepsy, stroke-like events, thrombosis, kidney findings, liver disease, and some endocrinology issues. This is the social part where patients can make questions to the doctors, can open new topics to talk about social support, epilepsy, whatever. And finally, the social part where they can put how they feel, if they have to share videos or photographs or everything. And this is all I want to tell you. I'm really grateful with the beautiful group that we have in Spain, including the patients, of course, the Spanish Association and the Portuguese Association, and always trying to be open to collaborate with everyone, to accept every suggestion coming from the families, from the doctors, and working as a team, because together everyone achieves more. Thank you.